person's hands. The story concerns a 48-year-old man who presented to the dermatology clinic with a 6-month history of painful hand ulcerations, as we can see on the acral surfaces of his joints. Has no muscle weakness or arthritis, and were offered CREST syndrome, which is a manifestation of scleroderma, Anti-MDAA5 dermatomyositis, Pyoderma Gangrenosum, cutaneous polyarteritis nodosa, and Bechet's disease. Well, this is not sclerodactyly. Pyoderma gangrenosa involves large soft tissue areas, looks entirely different. Polyarteritis nodosa can cause skin manifestations, but nothing that looks like this. And Bechet's disease involves ulcerations of mucous membranes, which is not the case here. Of the scleroderma syndrome, and the hands look like the picture that's shown here, and that's not the case with our patient for this week. Now, this MDA5 is a protein that's a part of intrinsic immunity, and this protein is involved in clearing RNA viruses, double-stranded RNA viruses. MDA5 is encoded by a specific gene, and mutations in that gene can result in several different syndromes. But in the condition that we're talking about today, these people develop an antibody against MDA5. They have fairly typical dermatomyositis, as we can see in this violaceous rash that this person has on the acral portions of his hands and also on the palmar surfaces. And these patients also get severe pulmonary disease. They get pulmonary fibrosis. And I was not really aware of that condition. So that's MDA5 antibody positive dermatomyositis. Now, Pyoderma gangrenosum, these huge ulcerating soft tissue lesions, are actually an autoimmune manifestation that usually accompanies ulcerative colitis or Crohn's disease. And although this looks like it's infected, these conditions do not get better with antibiotics. They're typically treated with glucocorticoids. Cyclosporin can be helpful sometimes, or dapsone, which is a non-specific immune modulating therapy. Polyarteritis nodosa can cause vasculitis. Livedo reticularis, as shown here, can cause skin manifestations, but nothing like our patient had today. Bechet's disease involves ulcerations of mucous membranes inside the mouth and also the genitalia. That was not the case in our patient today. The first topic at the New England Journal involves cyclin-dependent kinases. These kinases were discovered in the 1990s. They're serine-threonine kinases, and they're involved in cell proliferation. And there are a number of these: Cyclin D, Cyclin E, Cyclin A, and Cyclin B. And the discovery of this chain of events, how cells proliferate, was awarded a Nobel Prize in 2001. Now, you might imagine that since cancer cells proliferate fairly rapidly, that there might be a therapeutic niche here inhibiting cyclin kinases to impair the growth of cancer. And that idea has indeed been tested. An inhibitor has been developed against cyclin-dependent kinase 4 and 6. And this compound is called ribociclib. We've already inspected a previous paper in patients with breast cancer that's hormone-receptor positive, but HER2 negative. And in the earlier report that we inspected, one examined progression-free survival. In this subsequent continuation of this study, involving over 300 randomized patients in both of the two groups, the determined endpoint was an improvement in overall survival. So these are fairly advanced breast cancer patients that have also already been subjected to anti-hormonal therapies and other treatments, and they were randomized to this cyclin-dependent kinase 4 and 6 inhibitor or to placebo, and were followed for an extended period of time. And what we see here is overall survival is indeed better in the ribociclib plus endocrine therapy group compared to the patients that got endocrine therapy plus various other treatments. So the endpoint was achieved, an improvement in overall survival in these breast cancer patients. And if we look at this forest plot here, a variety of different subgroups, all of the various subgroups with some exceptions seem to benefit from this cyclin-dependent kinase inhibitor therapy. Now, I was surprised to see that large numbers of patients in both groups discontinued their treatments, and there could be various reasons, side effects, or, I mean, these cancers are progressive irrespective of what the treatment is, so that a large number of patients in the ribociclib group also discontinued their treatments for various reasons. And then other chemotherapies were offered to these patients. But nonetheless, progression-free survival is seen here, and overall survival, as we've already inspected, was better in the ribociclib group, so that it looks like the cyclin-dependent kinase strategy has something to offer to these breast cancer patients. Now, you're familiar with the Brca1 and Brca2, which are DNA repair genes that are mutated in some patients, under 5%, with breast cancer. We're familiar with that. It's a complicated story. The chances of a woman developing breast cancer sometime in her lifespan, up to age 80, is, I believe, about 25%. So a modest number of these patients have mutations in Brca genes. They usually have a family history that's positive with some relative developing breast cancer at an early age. What we appreciate less is that other tumors can also develop in patients with these mutations, including pancreas carcinoma, colon cancer, lymphomas, etc. And you're also familiar with the strategy that's also applied to patients that have Brca mutations. Their cancers grow fairly quickly, but cancers also have to be dependent on DNA repair genes. And since they commonly have some problems in DNA repair at other sites, they could respond to inhibitors of poly-ADP ribose polymerase 1 called Parp. So Parp inhibitors are applied with the notion that we can inhibit DNA repair in the tumor and therefore result in tumor regression. And this strategy was applied here in patients with germline Brca1 or Brca2 mutations, not in breast cancer patients, but these patients had pancreatic cancer. And the pancreatic cancers were limited to a group of patients who seemed to have a decrease in progression of their disease with a platinum-based therapy. So I think that this treatment was stacked in favor of the hypothesis, but I'm not an oncologist. The primary endpoint in this study was progression-free survival. So if we look at these patients, these are pancreatic cancer patients. Most of them have mutations in Brca2, although Brca1 mutations are also represented. Patients were selected with these mutations. They've already had conventional treatment for pancreatic cancer. FOLFIRINOX, gemcitabine, and other platinum-based treatments have already been applied, and these patients seem to have an arrest of their tumors on these treatments to be eligible for randomization in this study. And what we see here is that progression-free survival was indeed improved in the patients that got the Parp inhibitor compared to the patients that got the placebo treatment on top of all the other treatments that we're already receiving. And if we look at this forest plot, again, it seemed that various subgroups seemed to benefit from this treatment with the Parp inhibitor for their pancreatic cancer in a similar degree in these various subgroups. Were there adverse events? Yes, there were adverse events, and those are listed here. But for the most part, it seemed that these patients were able to tolerate this fairly well. So the authors conclude that 47% risk reduction in the progression of these pancreatic cancers occurred, but they do admit that the patients were they not only selected for BRCA mutations, but also they were selected for those patients that seemed to have an inhibition of the progression of their disease with the platinum-based treatment before the Parp inhibitor therapy was given. The next topic in the New England Journal involves umbrellas placed in the inferior vena cava to protect patients from massive pulmonary embolism. We've looked at these studies in the past. This kind of strategy is applied in patients that are not eligible for conventional anticoagulant treatment, although they are at a high risk for developing pulmonary embolism. And if we look at these devices, they look like this. The idea is to catch these thrombi so that they can't move up to the pulmonary vasculature. The devices are placed with catheter-based device. They have these hooklets at the end so that they're stuck here in the aorta. They can be removed, but removal with a special device to remove these things is not trivial. And they are associated with a variety of complications, so that in the earlier studies where this strategy was applied in a fairly broad-based fashion in patients that were poor candidates for conventional anticoagulant treatment, these devices could not be shown to be of benefit. But in this particular study, these patients were randomized to filters or no filters, and these were severely injured patients. And in patients that have been severely injured, not only do they have a very high risk of pulmonary embolism, they also have a very high risk of bleeding if they're anticoagulated at the site of their injury. So we see a fairly large number of patients that were randomized to receive the filter or not to receive the filter. And the patients were followed with ultrasonography of their legs, and they also underwent mandatory computerized tomographic pulmonary angiography. And the primary endpoint was a composite endpoint of symptomatic pulmonary embolism or death from any cause at 90 days after enrollment. And if we look at these patients, these are severely injured patients. We can look at their injury scores. The randomization seemed to be fairly even in both groups, no substantial differences between the two groups. But what we see here is that the primary endpoint, probability of freedom from death or pulmonary embolism, was no different in the two groups. And also the primary endpoint was not that common. So it didn't occur as commonly as one might have thought on the basis of these injuries from these patients. And if we look at the secondary endpoints, symptomatic pulmonary embolism, death from any cause, major bleeding, non-major bleeding, there were no significant differences in these two groups. Safety endpoints were also monitored. Clots were noted in the filter at the first attempt to remove the filter. The filter was adherent to the inferior vena cava wall. I would hope that that would be the case. Filter was not removed within 90 days, etc. These events are listed here. But at any rate, the use of vena cava filters, although this application is widespread in many trauma centers, in this randomized controlled trial could not be associated with any benefit in terms of pulmonary embolism or death at 90 days in these patients. The next topic concerns signaling by fibroblast growth factor receptors. There are a family of these receptors, and fibroblast growth factors are involved in proliferation of cells, and cancer cells proliferate. VEGF is a fibroblast growth factor-like compound that is involved in production of blood vessels that could play a role in metastatic disease, etc. I wasn't really aware of this, but mutations in fibroblast growth factor receptors are fairly common in patients that have transitional cell or urothelial cell malignancies. And in this particular study, patients with urothelial carcinomas were screened in terms of having any mutations in fibroblast growth factor receptors. And if they had these, then they were offered treatment with erdafitinib. And erdafitinib inhibits, these are tyrosine kinase receptors, or receptor tyrosine kinases, inhibits fibroblast growth factor receptor kinases. And this was not a randomized controlled trial. This was an exploratory study looking at the progression of the disease in these patients. So the primary endpoint here was the objective response rate. And these are patients with advanced disease. Most of them have visceral metastases. Some have decreases in renal function. They have impairment of their performance status scores, etc. And if we look at details here, in terms of whether or not the patients responded, in this tabular presentation doesn't look all that immediately obvious, but yes, indeed, their response rates, if you compare these values here with these values, it looks like the patients probably benefit from their treatment, and these numbers here are certainly better than those here. And if we look at a waterfall plot of the response rates, and this was an objective response rate. That means that the size of these tumors were monitored with imaging techniques. It looks like some patients didn't respond that well, but there are particular patients that responded very well indeed. And if we look at a forest plot here in terms of response, the response seemed to be independent of age or race or gender or performance scores, etc., so that it looks like this strategy might have something to offer these patients. So progressive free survival at 15 months, maybe not that great, but overall survival, so that at the end of 18 months, half of the patients were still there, and that would be better than would be expected. So I suppose we'll see a randomized controlled study on this issue shortly. Were there complications or adverse side effects from this treatment? Hyponatremia was fairly common, although the investigators didn't elucidate why. Stomatitis, asthenia, and other side effects are listed here. So the study met its primary objective with a 40% confirmed response rate, and I suppose we'll see a randomized controlled trial of this strategy against these mitogen-activated protein kinase pathways in the future. The review in the New England Journal is on measles. I had measles. Everybody in my generation had measles. So we can assume that people my age are all immune anyway. Cough, coryza, conjunctivitis, and the typical rash, a sequence of events that occurs within 4 days, is what's typical for measles in children and adults. And a vaccine was introduced, the MMR vaccine against measles, mumps, and rubella was introduced in the United States in 1962. And there used to be 500,000 cases a year of measles, but by 1968, these had disappeared. And measles was declared extinct in the 80s and 90s where there were hardly any cases, and now it's coming back. And it's coming back in adults, and most of these adults acquire their measles by traveling abroad, according to this review. That's true for the United States. In Europe, it may be different. Here's the typical rash that happens fairly suddenly. Remember, cough, coryza, and conjunctivitis, as we see in this young child. Always look inside the mouth when you have a patient with this kind of confluent rash. It's not yet confluent, but it can be. And these people develop these little white spots inside their mucous membranes. These are called Koplik spots, and Koplik spots are pathognomonic of measles. Usually goes away, but not always, because the patients can develop otitis media. They commonly get diarrhea, some get pneumonia, subacute sclerosing panencephalitis, we don't want that. Encephalitis, don't want that either. And some patients die from measles. That's the risk after natural disease. The risk after vaccination, these morbid events, in essence, disappear. So this is a wonderful vaccine. And the recommendations for using this vaccine, first year of life, two doses are probably good for a lifetime. Patients with underlying disease, HIV infections, etc., everybody should get vaccinated for measles. And the Center for Disease Control and similar agencies in Germany have given recommendations for measles vaccine, but not all adults or children become vaccinated because of various reasons that I'm not going to go into now. In Germany, a law has recently been passed that all children have to be vaccinated for measles. How that's going to come down in the courts remains to be seen. If we suspect measles, the patients develop IgM antibodies. Usually, by the time the rash appears, most of them have IgM antibodies. After 4 days of rash, they all have IgM antibodies, and there are also IgG antibodies that occur. And patients with measles should be isolated, has to be reported to health authorities, etc. And there's no need for us to concern ourselves about measles, because measles should be extinct from the planet. Pregnant women that have not been vaccinated for measles, there's even an intravenous immune globulin that's available to deal with this particular issue. Here's a mystery case for you. It will be resolved on the 8th of August, so the New England Journal tells us. Story concerns a 39-year-old woman with cyclic vomiting syndrome. Wasn't quite sure what that is, but she carries this diagnosis of cyclic vomiting syndrome and comes into the hospital at frequent intervals with that particular problem. But she also has a problem with substance abuse, and a urine toxicology test on this admission was positive for cocaine and opiates. Now, because of her cyclic vomiting syndrome and a variety of post-surgical issues, this patient is treated with acetaminophen, intranasal fluticasone, albuterol, promethazine, ondansetron, which is a serotonin receptor blocker that's supposed to help vomiting, polyethylene glycol, a multivitamin. Again, she has a history of using cocaine, heroin, marijuana, and MDMA, methylene dioxymethamphetamine. Shouldn't take that. So here's her laboratory stuff. And so 11 weeks before presentation, discharged at an affiliated hospital. You can look at all these values here. And then presentation at the hospital that she's currently in 11 weeks later. So she shows up again with cyclic vomiting syndrome, claims that her temperature at home had been 39.4 degrees. In the hospital on admission, it was 37.2 degrees. but she has a tachycardia at 165 beats a minute, which then suddenly increases to about 200 beats a minute. And if we look at this EKG here, she has a supraventricular tachycardia. We don't see any P waves. It looks like it's a paroxysmal supraventricular tachycardia. She gets adenosine, converts to sinus rhythm. Here we see P waves, and then there's a subsequent 12-lead electrocardiogram. So this woman, who's also agitated, thrashing in her bed, pulling at equipment and clothing, laughing and crying, seems to have a delirium, which would perhaps suggest withdrawal from certain drugs, but treatment is continued. So she gets adenosine for the supraventricular tachycardia. Urine toxicology screen is positive now for fentanyl, oxycodone, and cannabinoids. She gets all this imaging technique here, which shows that her ovaries seem okay. She's got some renal stones, but they're not obstructive. Looks like she has a somewhat fatty liver, since her spleen is denser than her liver, and the density of these two organs should be about the same in terms of Hounsfield units. So her doctors give her intravenous fluids, ondansetron, pantoprazole, fentanyl. She already got fentanyl, so I don't know why they gave her that. Lorazepam were administered, and the patient was taken to the ICU, and a diagnostic test was performed. Then the New England Journal actually asks our opinion. So all New England Journal readers, such as myself, were allowed to pick one of these diagnoses. Is this cyclic vomiting syndrome? Is this hyperthyroidism from Graves' disease? Does she have kidney stones? Well, we saw those in the CT. Is this opiate withdrawal? Could be. Is this an ovarian teratoma? Well, we didn't see it in the CT. Or is this a serotonergic syndrome? And that's what most of us thought. Now, this cyclic vomiting syndrome, I'm aware that cyclic vomiting can occur in some women with pregnancy that have severe vomiting during pregnancy. I'm aware that cyclic vomiting is associated with migraine headache. I'm aware that it usually starts in childhood, perhaps in children that are between 4 and 7 years of age. We weren't really given that history, and we weren't told that this woman had migraine. And in this portrayal here in German, there's no comment about cyclic vomiting syndrome necessarily being associated with drug abuse. I was interested to see that there's even a self-help group for cyclic vomiting syndrome. Their awareness day is on the 5th of March, and if you like, you can send them money. So that's cyclic vomiting syndrome. Their logo is a bucket. At least they've got a sense of humor. The whole story reminded me a little bit of Libby Zion, who changed medical practice and the training of house staff physicians 30 years ago, 35 years ago. She had to die to do this, but her story was a little similar to what's going on here. A young lady, unhappy, depressed, prescribed a monoamine oxidase inhibitor, receives a variety of different concomitant drugs for various reasons, including aspirin and oxycodone, and then is sent to an emergency room. And she also wasn't appreciated at the time, what we now call the serotonin toxicity syndrome, because after she got 50 milligrams of meperidine, she had a cardiac arrest and died. More about that next week. Here's an image from the New England Journal. We see here these papillomatous lesions on bronchoscopy in this patient. And this is human papillomavirus type 11 in this patient that has a low CD4 count because he's HIV positive. So these things have to be removed by laser treatments, and this is fairly tedious, but it's another example of a tumor being elicited by a papillomavirus. And here's the patient that we looked at last week with this carcinoma of the tonsil. And this is also elicited by a papillomavirus. Here we're talking about papillomavirus 16 instead of 11. So 2 examples of malignancies elicited by papillomavirus. Now the case in the New England Journal also troubled me a little bit. This 52-year-old man develops cough and low-grade fever, gets short of breath, comes to an emergency room, gets an oxygen saturation monitor put on him, and he has an oxygen saturation of 91%, which means that he has a PO2 of 60 on room air. That's actually not normal in someone that doesn't have underlying lung disease. Here are his labs, and you can look at these at your leisure. What troubled me is he's at the other hospital, so he's at St. Elsewhere. He spends 16 hours at St. Elsewhere. Somebody puts 2 liters of oxygen on his nose. That would give him an FiO2 of about 40 instead of 20, but his saturation didn't change at all. Did anybody measure blood gases? No. Somebody examined this patient and he had a 3 of 6 murmur, systolic murmur at the right upper sternal border. Now it didn't change with respiration, so it has to be a left-sided murmur, which means that it could be either aortic stenosis or mitral insufficiency. The N-terminal pro-B type natriuretic peptide was almost 5,000. Does this sound like a cardiac problem? So then this patient gets a chest x-ray, and I admit this chest x-ray is fairly tricky because we see a consolidative process in the right upper lobe. Left side doesn't look so bad. Cardiac silhouette actually looks pretty normal. So this would lead us in the direction of patient has fever, maybe he's got a pneumonia, maybe this is ARDS, but quickly in the hospital, his chest x-ray gets much worse, and now he has an infiltrative process in both lungs. He's got this straight left heart border that troubles me a little bit, and now he's got evidence of pleural effusion, which again should direct us towards a possible cardiac problem. Somebody did an electrocardiogram. In this first one, he's got left axis deviation, and he's got ST segment depression across the chest leads. That could be various things, but ischemia belongs to the differential diagnosis. And then we're still at the other hospital. 12 hours later, this ST segment depression actually looks a little better. And when he comes to MGH, I guess, he's got sinus rhythm. His left axis deviation has gotten better, and now his ST segment depressions have disappeared, which I think is interesting. But his pulmonary status gets worse, and now he's on a ventilator. So while at the other hospital, a bedside ultrasonographic examination was done, and he's got a hyperdynamic left ventricle. I think I could have probably diagnosed that with my fingertips. Nothing else was reported, which I think is profoundly disturbing because this patient had a left-sided systolic murmur. We can palpate his carotid upstroke and rule out aortic stenosis, so he probably ought to have mitral regurgitation, which might be responsible for his hypoxemia. Now, if we look at the differential diagnosis of hypoxemia, we've got 4 things. One of them is altitude. So you can look out the window to see if you're on Mount Everest, and if you're not, you can scratch that one. The next one is alveolar ventilation. Is this person breathing or not? So we can check that. Now, if he's on a ventilator, then the machine will breathe for him, so we can rule that out. Does this person have an anatomic shunt? That's possible. Or does he have a mismatch, an irregularity between perfusion and alveolar ventilation, a pathophysiological shunt? So we can figure that out by looking at the gradient of oxygen in his alveoli compared to his arterial blood. And to do that, we have to solve the alveolar gas equation, none of this was portrayed by the New England Journal discussant, so I'm going to tell you about it anyway. So here's the alveolar gas equation for sea level at in people that have an FiO2 of 21 that are not getting supplemental oxygen. So we can figure out hypoxemia and come to the cause. The discussant, ARDS, that's possible, but we have the possibility of cardiac cause here. Pulmonary embolism, that's also possible. Interstitial lung disease, less likely in this case. Cardiogenic pulmonary edema, highly likely in this patient. And so an echocardiogram is done here at MGH, and he's got a flail mitral leaflet. And I can't believe that the first ultrasonographer couldn't find a flailed mitral leaflet. So they send him to some nice surgeons that fix all that. And if we look at the specimen here, we see looks like he might have had a small infarct in papillary muscle. He had a cardiac catheterization. The main coronary arteries would look normal. Don't know exactly why, but he's got a flailed mitral leaflet, so his papillary muscle must have ruptured for some reason, and it's postulated that it did so because of a small infarct that was responsible for this flailed mitral leaflet. Now, we've looked at ultrasonography under emergency department conditions in some earlier reports in the New England Journal, and every physician that works in an intensive care unit or that works in an emergency unit should be able to conduct some ultrasonographic examinations on his own. As a matter of fact, I believe this should be taught in an anatomy class instead, that people dissect these poor old cadavers that never taught us much in the first place. So goal-directed echocardiography, identification of immediately life-threatening cause for hemodynamic failure, and this patient with hypoxemia had a hemodynamic failure. He was not in shock. Coexisting diagnoses, all of this is shown in this brief review that I show you here. Now, in the New England Journal, the ongoing Ebola virus epidemic is also discussed, and we've looked at Lancet papers where the development of a vaccine against Ebola virus looks very promising. But to vaccinate thousands of patients against Ebola virus is practically impossible. So the focus here is on vaccinating those groups in areas that seem to be at distinct risk. And the people working on this problem have done a remarkable job because they've already vaccinated over 100,000 people in the Democratic Republic of Congo, and they're being attacked by organized groups that are targeting response teams. There's deteriorating security because of the population's increasing distrust of the response effort, and that's the purpose of this. So the number of cases of Ebola virus are indeed increasing at the present time. That's a problem. Of course, it's understandable that the populations here that are involved are afraid, but the health workers that are trying to eradicate this epidemic are being markedly threatened by armed bands set on their destruction. And that's discussed in this report in the New England Journal. So global health and protection from these people that are involved in this epidemic, they actually conduct global health. All honor to them. In the Lancet, the first study involves birth control in African women that would perhaps like to not get pregnant. And the rumor has been spread in some parts of Africa that these birth control measures might increase the risk of getting HIV. And so the women that were willing to participate in this study were randomized to medroxyprogesterone acetate, a copper intrauterine device, or an implant, levonorgestrel implant for contraception. So this was a randomized controlled trial, and these women were then monitored in terms of their HIV risk. And Their various attributes are shown here, how much schooling they had, etc. And it looks like the patients were pretty much acceptive of their various contraceptive strategies. And these contraceptive strategies were also then discontinued in these women. And they had no problem getting subsequently pregnant. But what we see here, this is the real world down here. This is an expanded scale here. The chances of their getting AIDS was not great. And there was no difference in these contraceptive strategies. So the idea that contraceptive strategies increases the risk of getting AIDS seems not to be the case. In the next study in the New England Journal, I thought this was also interesting. This is a control trial looking at a nose operation, septoplasty. Deviations in the nasal septum are common. This is condition, if it's chronic, is commonly treated operatively, and whether or not the turbinates are operated on here is dependent upon the ear, nose, and throat specialist's strategy in dealing with the problem, but at any rate, the patients were randomized to non-surgical management, which consists of local care of one sort or another, to septoplasty with or without concurrent turbinate surgery. So here are the patients with their deviated nasal septums, and lots of things go up and down here, so there's a variability in this outcome. But I was interested in some of these scales here. The SNOT scale. Can't accuse ENT guys of not having a sense of humor. So the SNOT scale was definitely better in the patients that had septoplasty compared to the patients that had the non-surgical management. And the differences were not great, but the septoplasty group seemed to be do some better than the conservative management group. Two studies in the Lancet concern mapping malaria, falciparum malaria, which is a little more important than Vivax malaria, and comparisons are made here looking at the prevalence, incidence, and mortality of falciparum malaria comparing 2000 to 2017. And the good news is there's progress being made here. Falciparum malaria still exists, but in some portions of sub-Saharan Africa, falciparum malaria, at least particularly among infants and small children, where this is a major problem, seems to be getting better. And the regional falciparum incidence is decreasing. There's some gnashing of teeth here because progress is slow, but it is getting better. And if we look at these heat maps, a little more blue and a little less red in this map, this is mortality now in 2017 compared to 2005. So there is progress being made here. And in terms of Vivax malaria, we forget that this other form of malaria, which is much less lethal, is also common in other parts of the world, but that's also regressing with strategy. A lot of this in South America and Central America and in Mexico, but the bottom line is Vivax malaria has decreased by 42% since the year 2000, the burden of Vivax malaria, and I think that that's a substantial improvement. Then the review in the Lancet I didn't understand. It's entitled Sexual and Reproductive Health and Rights and Population Policies. It's true that the world's population has almost doubled from 3.5 billion to 7.5 billion between 1945 and today. And the postulation is that it may double again in the next 80 years, or between now and 2100. This, I think, would represent a problem. The authors here state, we identify population growth and sustainable development, comma, people on the planet, comma, and reproductive and sexual rights as the three most important issues facing the field today. So I don't think that driving an electric car, although I do think that's a good idea, is going to have much of an impact on this. And you can read this review and figure out whether or not the authors here know what they're talking about. Now, in the Lancet, we look at this case report. This is a poor 51-year-old man, and he is operated on 3 times for the same inguinal hernia, and it doesn't help him. So somebody does an imaging study, and his hernia looks like this. I'm not an expert in this, but this lesion here is not an inguinal hernia. This is a femoral hernia, which femoral hernias are not very common in men. But then he's operated, they convinced him to be operated on for a femoral hernia instead of an inguinal hernia, and then success was accrued. And then we'll stop with this case presentation from the New England Journal. 52-year-old man comes into an emergency room with nausea, vomiting, and he's lethargic. He's been getting worse for the last 5 months. So he's examined by this physician here, and I wouldn't renew her contract because she doesn't take his clothes off. She listens to his chest through his clothes, and she doesn't take his clothes off. I can't believe that. If they draw these kinds of illustrations in the New England Journal, somebody's got to talk to the illustrators. This will not do. At any rate, here's this poor guy. He's got a number of healthcare issues, glaucoma and low back pain, and he gets a number of drugs for this, that, and the other. And prostate cancer is fairly common, and so family history of that. He's been living in the United States for 30 years, and he works in information technology, and he looks pretty unhappy. So he gets some blood work done, and his white cell count is a little elevated, and his platelet count is a little low, and it's hematocrit. He's not really that anemic. His hemoglobin's okay. He's got a little bit of metabolic acidosis. So probably ought to measure his blood gases. But at any rate, then the New England Journal explains to us a little bit about calcium metabolism and how it's absorbed from the small intestine. And we need vitamin D to do that, and phosphate. And then we need parathyroid hormone, and it comes from the parathyroid glands. And it has to do with regulating extracellular calcium. And why are they telling us all this? Well, they're telling us all this because this patient has hypercalcemia, and that's responsible for his lethargy. And when we measure calcium levels, we should consider the albumin level, which wasn't given in this laboratory workup. And if the albumin level is low, we need to correct the calcium value for the low level of albumin, and there's a little formula that you can utilize to do that. But here's this patient. He's got a calcium of 16, so we probably don't have to correct his calcium value, although he's a little hypoalbuminemic. It's going to be above 16, which is twice the normal range. His parathyroid hormone level's low, so this is not a parathyroid hormone problem. Then somebody measured parathyroid peptide. They're really talking about parathyroid hormone-related peptide, and they should call it that. Vitamin D levels are low. That doesn't seem to be the problem. What troubled me about this presentation is if you go to the trouble to measure calcium, please also measure phosphate so that we can figure out what's going on here. Does the patient have true hypercalcemia? Yes, indeed he does. Is it dependent on parathyroid hormone? I wouldn't think so, since the PTH level is low. So this is a PTH-independent hypercalcemia. Now, this material here is really PTH-RP. It's encoded by a separate gene. It has about a 30% homology to PTH. And if we have patients that have the hypercalcemia of malignancy, and it's not multiple myeloma, then it's probably due to PTH-RP. And here we have it. His PTH-RP level is above 2, so it's elevated. So this is parathyroid hormone-related peptide problem. And there it is. So now we have an explanation. Now we have to know, where is his cancer? Well, the doctor didn't take his clothes off, so I guess she doesn't know where his cancer might be. Hypercalcemia of this nature should be treated with volume expansion, and isotonic normal saline for that is okay. So that's what should be done immediately while we try to figure out what's going on here. Now, since the patient wasn't subjected to a physical examination, he had to have a PET. And what we see here is a whole bunch of large lymph nodes, axillary, neck lymph nodes. Got a bunch of these big lymph nodes also in his groin, and his spleen is enlarged and probably hard as a rock, although I don't know for certain. So he's worked up for these conditions and has a biopsy of these things, and these are a bunch of T cell markers. And what this patient has is he has a T cell lymphoma, and these can be caused by the human T lymphotropic virus type 1. And this virus was discovered by Bob Gallo. Bob Gallo went to the same medical school that I did. He was a little ahead of me, and he ended up becoming a brilliant virologist, and he discovered this human T cell lymphoma virus, and he showed that this is a retrovirus. So it relies on reverse transcriptase for its incorporation into DNA. And Bob Gallo was involved in an argument with Montagnac and co-workers concerning the discovery of HIV, and probably did some things that he shouldn't have done, so he didn't get a Nobel Prize. Although I think the discovery of the first retrovirus to cause a human disease is worth of some note, and he did get the Lasker Award. I think he might have even gotten 2 Lasker Awards. So that's what this looks like, HTLV, causing this lymphoma. And at least the parathyroid hormone-related peptide problems that I've been confronted with are mostly solid tumors. And I really wasn't aware of the fact that HTLV1 can also result in PTHrP elaboration that can cause hypercalcemia. So he's treated for this lymphoma and seems to do fairly well. So those are the teaching points. Thank you for your attention. More of these journals next week.